Thank you for joining iMeet.
And Yvonne?
This meeting is now being recorded.
Yes, I'm here, Yvonne Cookenbaker.
Thank you very much for helping me with your last name from the American Lung Association. And Yocasta Laura from AARP. Okay, at this time, is there anyone that I have not announced, name and organization?
Diane Battaglia from Mercy.
Thank you, Diane. Okay, well, thank you for taking the time to go through everyone that is on the call. Thank you for being here. And we will go ahead and advance through some of these slides. So the agenda for today, we will have a recap of the meeting schedule and topics as they've been disseminated. We will have a presentation of the best practices for sustainable delivery networks in the state and from across the nation, and to see what we can potentially do in Pennsylvania. We'll have an opportunity to have a live question and answer panel with Diane Davis, Senior Director of Health Self-Management Services of Partners in Care Foundation from California, as well as Jennifer Raymond, Director, Elder Services of Merrimack Valley in Massachusetts with the Healthy Living Center of Excellence. Hopefully we'll have time and some active discussion with a summary of action steps and then adjourning the meeting. So our meeting schedule so far, we've completed meetings 1 and 2, and we are currently at meeting 3, where we are discussing the overview of best practices for what is a sustainable delivery network for evidence-based self-management programs. If you can scroll down or look down to meeting 6, we will be sending out the poll of which meeting date works best for the majority of the group. We are leaning towards August 23rd from 12 to 2 p.m. if that is possible. But of course we will take the responses to the poll that will be embedded in the survey that we will be sending out after the meeting today. For anyone who has not been able to attend meeting 1 and 2, we do have Google Drive set up. I understand that some of you are unable to access that through your organizations due to firewalls and limitations. So we are exploring whether or not an FTP site would be more accessible and potentially a way of communicating securely with your organizations. We will go ahead and ask that question in the survey so that we can determine whether or not we want to include those, utilize those resources for setting up an FTP site to share this information. So the goals for the meeting today, for number 1, our main goal is to create a statewide awareness of what the nationwide best practices are for sustainable delivery of evidence-based self-management programs, as well as help to provide a snapshot of what our state looks like as far as delivering evidence-based self-management programs compared to best practices. And thirdly, to identify at least 3 action steps that we can begin with input from all of you, whether it is on the line today or in the post-survey, that will help us move Pennsylvania towards a sustainable delivery network of evidence-based self-management programming. Any questions so far? So we have taken all of the resources that you will see today from the best practices from the National Council on Aging. This is a public access website that all of you are welcome to review and explore. There is a tremendous amount of information about work that has been done since early 2000 in this area. So there is a wealth of information here to help new programs, existing programs, as well as groups like ours trying to make decisions about some implementing best practices and what might work in our state. So we reviewed this slide at the last meeting, we are going to focus today on partnership and infrastructure and delivery systems. Last meeting, we talked about financing, the third item. Next week, we'll be talking more about marketing and promotion and referral systems. So just as a reminder from the last meeting, we talked about how CDSME, which is Chronic Disease Self-Management Education, falls in meeting the AAA model objectives and the model. So we are looking at delivering prevention and health promotion programs that impact the entire system, whether it's families, outcomes of primary care practice, helping to integrate education and services into the whole spectrum of healthcare. So let's define sustainability. I think it's always good to start with a definition. So if we look on Wikipedia, we see that sustainability is derived from a Latin root, meaning to maintain, support, or endure. Just a standard Google search reveals that it is the ability to be maintained at a certain rate or level, and of course there's other potential definitions. Sustainability, as defined by the National Council on Aging, is ensuring that evidence-based programs are readily available and easily accessible to older adults over time. It also means integrating and embedding evidence-based programs so that they become routine and an integral component of organizational operations. Having sustainability is also about having effective leadership and participation of a variety of staff, partners, and stakeholders. So we truly appreciate your participation in this process. And lastly, but not least, it also is an improved through careful attention to other elements of offering evidence-based programs, which include planning, implementation, outreach, recruitment, and evaluation. So what are we developing and sustaining through this process? We are, over the past 2 years, in partnership with the Department of Aging, who began in this area with chronic disease self-management programming from the Self-Management Resource Center, which was formerly known as Stanford University Patient Education Research Center, in building the capacity in delivering evidence-based self-management programming across the state. So this programming includes a focus on diabetes for this Administration for Community Living grant period of 2015 through 2017, but it also impacts chronic disease, and the goal is to allow these programs to live beyond the Administration for Community Living funding. It means building infrastructure that is self-sustaining through a network of partners. It is also a network that provides access for older adults and adults with disabilities and diabetes or other chronic disease conditions to which self-management education can benefit the individuals, communities, public health, health systems, and social and economic spheres. So let's take a look at the first best practice, leadership and partnership. So taking from that diagram that we presented earlier on, partnerships mean that we engage stakeholders, we set common priorities and goals, create a sustainability committee, which is essentially what we are doing now as an initial focus, as well as securing resource contributions from diverse partners. These partners, this is just a list of potential partners. Many of these are already involved in this work, and this is definitely not an exhaustive list on the left. So the goal of these partners is to build strategic partnerships that will expand program reach and embed these services into health and long-term services and supports. Partners are also aimed to increase program awareness through shared messaging, as well as integrating into referral and delivery systems. And our main goal is to utilize multiple and variety of partnerships to reach targeted underserved populations. So our current partners on the Pennsylvania Community Living Initiative through the Administration for Community Living 2015-2017 grant are shown here. This is our main core of partners, most of which signed on in the grant writing phase, which was a rapid onset, and many of you know what it's like to respond to these proposals and gather all the necessary resources and partners. And then thereafter, we had United Neighborhood Centers of Northeast Pennsylvania join our partnership, as well as Quality Insights, which is our Pennsylvania, as well as 4 other states' quality improvement organization. And not on here, well, actually it's on the left-hand side, Center in the Park also joined after our partnership. And this isn't an all-inclusive list of who we are partnering with. There are many other host sites and partners throughout the state that are offering programs through partnership with Center in the Park, Quality Insights, United Neighborhood Centers, and Department of Aging through their network of area agencies on aging. Additional partners to consider would be behavioral health partners, Parks and Recreation, as well as other public health partners, healthcare systems, and providers. We will include a question for you to respond to in the post-meeting survey, through which we would like to collect additional partners if possible. And of course, if you'd like to share that information now while it's fresh in your mind, please use the chat box and we will collect that information from you. So the role of our partnership is to provide, if you look on the left, overall direction and leadership, a coordination of logistical processes, network development and maintenance, quality assurance, which is already built into the evidence-based programming from the Self-Management Resource Center, as well as other evidence-based programs, as well as providing stability when we look at the fiscal sustainability of programs. So for the Self-Management Resource Center's evidence-based self-management programs, which include diabetes, chronic disease, chronic pain, just to name a few, there is a license that is required. That is a 3-year license, and it depends, the license is expanded based on the number of programs that are offered, as well as the number of workshops and lay leader trainings that are offered under the license. Partners play an integral role in infrastructure development, meaning the securing host sites to offer these workshops, providing workforce, which is on the next box, and also some of the other items that we'll take a look at. So workforce training, development, and ongoing education and support. This is a big part of supporting evidence-based programming and making sure that we have a sufficient team of individuals that are trained and committed to offering workshops, supporting those that facilitate workshops, which are called lay leaders. And then if we look at the last 3 boxes, data collection is an important part of, I apologize, got to pop up here. Data collection, analysis, and reporting is a requirement of the Administration for Community Living grant. Can everyone still see my slides?
Yes.
Okay. Thank you.
No, I can't. No.
Nope.
Okay.
It just lost you off.
Okay, I'm going to put everyone on mute for just one moment. Okay, so I'm going to keep talking through the slides. So I mentioned data collection, analysis, and reporting. There is a requirement with the Administration for Community Living grant to report the number of workshops, the number of participants and completers, as well as forms that are approved by the Office of Management and Business, OMB, where we collect information that is not attached to people's identity about the chronic conditions that they have, how they found the program, and some other information. We are also collecting pre- and post information about confidence and satisfaction with their self-management program, as well as increased ability to manage their chronic condition. There are elements of marketing and promotion across the partnership, as well as integrated referral strategies, as well as implementing feedback loops to make that connection back to clinical partners about the participation of their patients in these programs. So moving on to leaderships and partners, there are other approaches to consider from the National Council on Aging. The first one, again, I think is represented by this group, but we will make a decision about whether or not, and we want input of whether or not we should develop a steering group or an advisory council to provide ongoing overall direction of this programming across the state. There's also recommendations to coordinate with universities or other separate non-governmental agencies for fidelity monitoring, program evaluation, and technical assistance. For us, on this grant and for many other projects, it's PHMC, Public Health Management Corporation's Research and Evaluation Group, provides this level of expertise for this area. And then the third bullet is creating a network hub. So there are, across the nation, there's a variety, up to a point, this grant funding was provided mainly to state agencies. In the 2015 proposal RFP, they opened it up to nonprofit agencies. There are many nonprofit institutes and organizations that are serving as a network hub to coordinate program delivery and provide technical assistance, and all of them in one way or another are in partnership with state agencies. And you'll have an opportunity to see some of those in action. We'll take a look at some of them a little bit later on. Any questions at this point? Get this back up. Okay, bear with me. Okay, so we'll take a look at centralized and coordinated logistical processes. This is another best practice element through the National Council on Aging, and this is described as having centralized and coordinated marketing, recruitment, and enrollment. We have large numbers of people who need self-management education in Pennsylvania and across the nation. When we're looking at diabetes, we're looking at very large numbers, and if we don't have a centralized, coordinated effort to reach those individuals, recruit them, and enroll them, it's just difficult to reach the numbers that need the programming. So other things that are included in centralized and coordinated logistical processes are statewide, having a statewide program name or shared branding in the marketing materials and tools, as well as toll-free enrollment numbers and information numbers, and a centralized website. And again, I provided the website that you can look and learn more about this, but we'll talk a little bit more about this in just a moment. So what I've done is taken the list of best practices for centralized and coordinated processes, and used the colors around the boxes to demonstrate where we fall in Pennsylvania around this area as far as a statewide coordinated delivery system. So we do not necessarily have a statewide brand name for evidence-based initiatives. There are options there. So again, this is where the multiple partners of the leadership group, we hope that we can get some feedback on this. And this isn't a decision that we'll be making today, but maybe something we want to put on our action list in our sustainability plan. So yellow means that we have some branding and names from various organizations. There isn't a statewide brand name, so to speak, for the chronic disease self-management education programs. Right now, we're just using Pennsylvania Community Living Initiative to describe the programming that is happening as a result of the current Administration for Community Living grant. The next best practice, ongoing public relations plan with multiple promotional strategies. There isn't a formal plan in place. We have worked within our organization and our partners to try and address some of these things, but this takes some time, and you'll see what other states have done as far as being able to harness this area. We have created in the next block some standardized marketing materials I'll show you in just a moment. Is there a formal process for using former participants or other ambassadors to promote the program? I think across the state this is something that is generally encouraged, asking people who go through the program to promote it to their friends and family. And in our partnership with the Department of Health, through our Pennsylvania Community Clinical Integration Initiative, there will be the launch of the Make a Choice campaign, in which people with diabetes will be highlighted as success stories that have gone through self-management education programs and have been successful in their work, as well as diabetes prevention programs. So there is some structure in place. The question is, how do we engage that system that the Department of Health has done excellent work in establishing, and whether or not we want to take that route. Is there a statewide website for CDSME? Most of the information regarding the chronic disease self-management education programs is hosted within organizations, so there isn't a statewide website, nor is there a statewide workshop calendar. Again, the Department of Health has created a statewide county-by-county interactive map that lives on their website, which highlights diabetes self-management education programs which are accredited or recognized. So it does not include these evidence-based programs, but we are working towards a process to get these programs accredited and recognized, but that is not an easy feat. So that process is in the works. So we need to decide how do we publicize this statewide and have an accessible calendar that no matter where people are across the state, they can go to one point to identify resources in their community. We do have a statewide toll-free number. It's not being widely used, in which people can call into the 800 number and get information and referrals out to the programs. That's happening within HPC at the present time, and going to our two lead navigators, both of which are bilingual and able to assist people to identify workshops in their area. We don't have a single or coordinated referral mechanism. You'll see some other best practices across the state where they have implemented some of these processes in through their websites and through other avenues. We don't have an online registration for CDSME. We would like to. That would be one way that providers or community partners or people living with diabetes or other chronic diseases can self-refer to programs and essentially sign up to learn more about programs that are available. We do not have a statewide mechanism for tracking wait time or wait lists. So for individuals that are interested in being signed up for a program when it gets scheduled, that would be something to consider. So all of these practices, especially in areas where there is low access to programming, limited transportation, things like that, we want to know, who is ready, willing, and able and interested in attending programs so that we can then, when the program gets scheduled, or know when there's enough volume of people waiting for programs to then schedule a workshop in that location. Again, we don't have a consistent or coordinated intake, enrollment, and registration process. I think this would definitely benefit the state, as we have learned from the best practices. And are there activities to educate potential advocates and decision makers about CDSME? We work very closely with the Department of Health, Department of Aging, Department of Human Services around this topic. We just attended with multiple partners that are on this call today, the Diabetes Action Network, where we are together talking about the various aspects of diabetes self-management and diabetes prevention, and the resources that are available, and how do we elevate the awareness to legislators and decision makers and policy makers across the state and nationally. Okay. One moment. It's not coming up for me.
Sorry, can you share it again?
I apologize if you can't see my slides. For some reason, the screen sharing keeps, Okay. Technology works, and sometimes is challenging. I think everybody would agree it's better than getting in a car and driving several hours to try and meet face to face, so thank you for bearing with us and your flexibility. So let's take a look at some of the resources that have been developed through our partnership. Again, we've used NCOA templates that have been created. We have adapted using the Self-Management Resource Center, formerly known as the Stanford Patient Education Research Center, their branding steps to healthier living, name and logo. We have an option for partners that want to utilize the resources to put their logo on it, in addition to HPC's logo. So there is an element of co-branding. We do make the toll-free number available to everyone. We're working on a centralized website. It is in development, and it will be very simple. As you know, websites take a lot of resources and coordination if it is truly going to be a statewide effort. But for now, our goal is to be able to offer resources to everyone across the state, and especially publicizing calendars and things like that so people have access to the information. So here we see, hopefully everybody can see my screen. You should be looking at flyers. These have been shared with our partners, and people are using them in various ways. We've provided them in modifiable formats and in PDF. So this would be an example of an overview flyer that could be targeted at host sites. You can see on the left-hand column where it says Get Involved. Different ways. I apologize for the background noise. Our conference room is getting a little bit warm, so we just opened the door for a little bit. To get involved, it could be a primary care provider that would refer a participant or a community-based program. It might be a participant who sees this flyer who wants to join a workshop. It might be somebody who wants to become a peer leader, or also known as a lay leader. It might be a host site that wants to offer a workshop, whether it's a library or a recreation center, a restaurant. You know, the sky's the limit as far as where workshops can be offered. Becoming a partner, as we shared earlier, there are multiple ways to partner with evidence-based programming delivery. It could be a partner who wants to promote workshops or donate resources and supplies. We know that people like to come and be fed and get gifts and things like that, and we know that there also are limitations and incentives and things like that that can be provided by law, but you know, as far as providing, you know, partnering with a supermarket or a restaurant that might be willing to donate healthy snacks and things like that. So we try to provide some examples of ways people can partner. And then on the right side, and all of this was taken from the language from what was then the Stanford Patient Education Research Center. So the details of the programming, who it's targeted to, and how the program is delivered. These flyers are geared towards people with diabetes, so if there's a person in a doctor's office or at a community center and there isn't necessarily a workshop to be promoted, this is a general flyer that can live on without any dates, and it has the resource information in which people can get more information and get referred to their local providers. And thirdly, this would be for a workshop that is actually scheduled, and the number at the bottom to register would be transferred to that local person. So rather than coming to us and have people registered right now, it's going back and community-based organizations, whether they're senior centers, area agencies on aging, recreation centers, senior living homes, can use this flyer to personalize it for them. So these are some of the things that we have developed thus far. We haven't changed the name that was assigned as a part of the grant. I think, or we think, that would be something that a group like this would want to provide input on rather than making decisions on how to represent a statewide effort like this. So infrastructure, best practices on infrastructure and delivery systems, again from the National Council on Aging. So infrastructure and delivery system best practices from the framework means that we have to designate program champions, engage executive leadership support. We need decision makers to be able to determine how this program is offered and supported. We need to have sufficient staffing and training of those who deliver the programming, as well as have centralized and coordinated processes so that we can all work together and make it easier to get folks that need to be registered for programs and need these services to access them. So what is filing in below are what is required under staffing and training. So if you go to the very bottom, we mentioned earlier on that licensing is required to deliver what was formerly known as Stanford's program, which is now Self-Management Resource Center. There is the license that's required. There are multiple licenses across the state. Some states have one license, one umbrella license, and everybody operates under the same license. Some states have multiple organizations that have licenses. So there's a lot of flexibility. What the license means that, so for instance, Pennsylvania Department of Aging has a license that covers all of their area agencies on aging. One license, just a base license, allows for 100 workshops and 6 lay leader training. So lay leaders are trained, if you look at the top bullet, by master trainers. These individuals are trained by T trainers, as they are named by Stanford, what was formerly, as I apologize to have to keep saying this, but Stanford's, formerly known as Stanford's program. So master trainers remain active by training lay leaders and or conducting workshops on their own. And they are all trained in chronic disease self-management program as their base training, and then they are cross-trained in one of the other areas that the Self-Management Resource Center offers. Lay leaders are supported by active master trainers and trained. So 2 master trainers train a team of lay leaders. And some of the statistics from the National Council on Aging is that when we get a lay leader, and this may be a volunteer from the community, so an older adult who has diabetes and goes through a diabetes program, then gets trained in a group by 2 master trainers. And the national statistic, based on the data that's been gathered by Public Health Management Corporation Research and Evaluation Group, that those lay leaders on average teach about 1.5 workshops per year. It doesn't mean they teach a half a workshop, but from all the lay leaders and all the data that's submitted through the National Council on Aging, we get about 1.5 workshops. So when we assess how many lay leaders we need to deliver workshops, it's quite a large number, so there is significant effort that has to go into supporting the cultivation and recruitment and maintenance of lay leaders across the state. We need host sites that are locations where workshops are offered. Those host sites may or may not have staff that are actually trained to offer workshops. There is an element of data tracking and management that is required. I'm going to show you in just a little bit some websites that in other states that do this work, and we've already gone through the licensing piece. This was quite a lot to cover. Any questions at this point? So let's take a look at some best practices in action. So we'll have an opportunity to hear from Jennifer Raymond, who is from the Healthy Living Center of Excellence in Massachusetts. She recently, her position changed, where she is actually the director under the Elder Services of Merrimack Valley. So as you can see, they have a beautiful website, and it is through the Healthy Living Center of Excellence. Most of the best practices, what we see when we go to their websites, is they have a one-stop number, they have an opportunity to make a referral, they have program schedules and calendars as well as descriptions. Many of the programs, oh, and this is a picture of Jennifer down here. They have, it's a one-stop resource for information about how to get involved, what the program is, as well as allowing people to access programs through program schedules. So I'm just going to go externally here.
Hi, Gina. I just wanted you to know that Diane is on the call now as well.
Hi, Diane. So I'm just going to just give you a snapshot. You all will have these websites available to you. But I'm just going to give you an idea of how some of this information is presented. The Healthy Living Center of Excellence does more than diabetes self-management programs. They also do diabetes prevention programs, as you can see. So, this is a best practice. This is the way states who've been successful in this and can share information easily with partners and participants. Many best practice states have a way to make an online referral, whether it's a self-referral or a referral from a healthcare provider. So you can see here, there is the drop-down menu. Okay, you can't see, is it not loading?
No, you have to share it.
Okay.
It goes to the share.
Okay. It's not allowed.
There it is.
Okay.
This is a lie.
Okay, I apologize for the delay. All right, where was I? Okay, so, if we go to Partners in Care Foundation, when you receive the slides, you'll be able to click through. Again, the states that we've invited to speak with you are states that we really like the way that they do business and what they've done with multiple sources of funding to bring a statewide effort that's happening to coordinate these services. Our own state does have the Live Healthy PA website. So again, we have lots of resources within our state that we could potentially leverage, and that those are some of the decisions we would like to be able to make as far as establishing our sustainability plan. Is there anything that anybody would like me to click on at this point in time? Okay. All right. Okay, so Partners in Care Foundation, you heard Diane introduce herself. She will be available. We'll be going through some question and answer in just a moment. So Partners in Care Foundation is located in California. I don't want to go into too much detail because I'll let Diane give an opportunity in just a little bit to provide some background. But again, they have similar access around programs, and they partner with with a statewide coalition, the California Healthy Living, is it Coalition, Diane?
Yes, it's California Healthier Living Coalition, and that was started by the California Department of Aging, the California Department of Public Health, Arthritis Sector, Dignity Health, Kaiser, and Partners in Care Foundation. And it's been in existence for probably 7 years now or so.
And we can go into a little bit more with some of the questions a little bit later on. So Partners in Care Foundation has been extremely successful in creating a statewide network of providers across the very long state of California, where they have an active system to be able to enroll members into programs across their state through a contact center, as well as, again, a lot of the elements that the Healthier Living Center of Excellence has, which is a process to provide online enrollment of programs, as well as seeing a calendar of programs that are available. And they also do much more than just evidence-based self-management programming. There are many arms to Partners in Care Foundation. So through the California Healthier Living Coalition, there's ongoing education and trainings that are provided. Those trainings are provided online. There's a delay in what you see. You can see here there are workshop stories and things like that. So again, a very robust, well-developed website that provides a lot of information and resources for people that are interested in accessing the information. Okay, QTAC, Quality and Technical Assistance Center of New York, is another best practice. QTAC has created something called Compass, which is a data collection system. Oops, I didn't activate the link, I apologize. And I want to make sure we have enough time for our Q&A. We can always come back to this. So again, similar to the other best practice states, there is easy access to information, calendars, success stories, how to become involved and partner, how to find a workshop. There is an online form that can be filled out, as well as an opportunity to partner in their statewide data collection system, which everyone has, each partner has access to this data and can report the data so that there's a statewide robust data collection system to report the successes, which helps promote funding, as well as ties into many other elements. Unfortunately, Lisa will not be able to join us today. We did invite her to the panel, but she was pulled out for a mandatory training and had to inform me of that yesterday. But if anyone does have questions, again, we will have an opportunity for you to ask those questions in the post-meeting survey. We will share those questions with the panelists and report back in a written Q&A document for you, as well as have an opportunity to discuss them on a future call. Another state that I am incredibly impressed with their work is Florida Health Networks. This is a nonprofit organization that, similar to Partners in Care Foundation, has created a statewide network. Massachusetts and California have also been successful in getting their DSMP program accredited and recognized. So has Florida been successful with that? And there are also many different models for that. Florida has one umbrella accreditation recognition, and then it's shared across the state among the multiple partners. So again, these resources will be available to you. A lot of the same elements are available on each of these websites. Calendars, how to become a partner, and so on. So I want to pause just to collect any thoughts, feedback, or contributions at this time. Okay. I'm not sure. Jennifer, have you joined the call?
I am. Thank you, Gina. I'm here.
Hi, Jennifer.
Hi.
Thank you so much. Yeah, so I'm going to introduce the both of you. I'm going to let you do more of your own personal introduction, but you heard Diane Davis, who's the Senior Director of Health Self-Management Services at Partners in Care Foundation, and has years and years of experience in creating a statewide network and implementing best practices in California. And then, as you heard, we have Jennifer Raymond, who's the director, and this is a new title. Maybe you can explain a little bit more of that, with Elder Services of Merrimack Valley through the, and you can explain a little bit more about the Healthy Living Center of Excellence and how that overlaps in your role. So we have some questions prepared for the panelists, but what we would like to offer, those of you who have questions that you would like to ask of Diane and Jennifer, if you would enter them in the chat box. If you would prefer just to ask your question, just unmute your telephone and state your name, your organization, and ask your question. So before we start to do that, I would like to offer Diane Davis an opportunity to introduce herself and provide some additional information that she would like to share about her and her organization.
Hi, this is Diane, and I have a master's in public health. Spent 15 years working in large health systems on the East Coast, then moved back to California, started working at Partners in Care, and then really had you know what, I am in transit, and I just got into my house. Hi, now I'm good. I have been at Partners in Care for about 5 years, and Partners has been the state technical assistance office for evidence-based programs for the state of California and the city of Los Angeles for the city for about 13 years, and for the state for about 8 years now. And we developed, with the other organizations that I mentioned previously, we developed the Healthier Living Coalition, which then was basically a platform for us to begin to develop our network when a large California managed care organization came to us to ask for us to be able to provide on a state level a network of providers for CDS-ME.
Okay. Thank you, Diane.
Yeah.
And okay. Would you like to continue? Okay. I'm going to give the same opportunity for Jennifer Raymond to provide her introduction and some background on some key things that she'd like to share from Massachusetts. Thank you, Jennifer.
Thank you, Gina, and thanks everyone for taking the time today to learn a little bit about the network that we have here in Massachusetts. My name is Jennifer Raymond. I am the director of the Healthy Living Center of Excellence, which is the statewide network for the implementation of evidence-based programs in Massachusetts. We are based out of Elder Services of the Merrimack Valley, and Elder Services is the largest area agency on aging in Massachusetts. My experience is much more on the business side. I have my master's in business administration as well as my Juris Doctorate, so really come to this work from a frame of looking at sustainability and engaging multiple partners and understanding the different challenges and barriers that folks have when they participate in this kind of work, and helping them to, as organizations, overcome those barriers to get us to a point where we can all benefit from the contracting with healthcare providers and others. Just quickly, our network here in Massachusetts is the Training and Technical Assistance Center for the state, and has been in that position for about 12 years. We are also, as I mentioned, the statewide hub. So we are the central hub for about 90 different community-based organizations from all different counties of the state, and these community-based organizations contract through the Healthy Living Center in order to deliver evidence-based programs in their community. And that sort of subcontracting that they do with the Healthy Living Center does allow us to have one single provider network in the state for these programs, and has certainly helped us to ease the burden on healthcare systems in contracting. So I'm happy to talk more about our experience and also learn from the great work that you're doing in Pennsylvania. So thanks so much.
Thank you so much, Jennifer and Diane. Okay, so our first question for the panelists, and again, anyone that is on the call and listening, please feel free to ask your questions. So our first question for the panelists, and we'll have Diane go first and then Jennifer. Thinking back to your early days and working towards establishing a sustainable and coordinated network of evidence-based program delivery, what were some of your first, second, and third greatest lessons or wins that you had within your state?
So I think in California, the first and probably the biggest win that we had was really that we had a plan come to us. We had Blue Shield of California come to us and ask us to stand up a network to provide chronic disease health management programs across the state. And that's quite unusual, and I think when you hear Jennifer's story, you'll see that it's very different from a lot of other states. So we knew as we were going into developing I guess I should say formalizing our network, not so much developing it, because the second, number two item, I guess I would say, was we were lucky because we already had the Healthier Living Coalition in place, which had been a much more loosely organized network, but a group that came together to share best practices, to talk about issues that were happening in different regions of California. And because of the size of California, LA County alone is the size of the state of Connecticut. So we are a huge state, 30 million people, and very varying, huge rural areas, and obviously huge urban areas. So this group that had been established and come together from being very loosely connected, maybe 7 or 8 years ago, to being somewhat more formalized when they came together as the Healthier Living Coalition, which was about 5 years ago, to then, after Blue Shield came to us and asked us to put together a network so that they didn't have to go out and contract with each individual organization across the state, we already had a lot of relationships and trust built up. And I think that's really key to our success, was the fact that when we then decided to create this more official or organized network hub with the contact center and contracting elements, we already had a lot of those relationships in place and a lot of trust that had been built up and best practices that had been shared, so that organizations were more willing to come together in a more formalized, contracted organization. And then I think third is that we've had an amazing champion in Laura Conley, who's the head of the Department of Aging for the state of California. And Laura has, she's been the leader of the Healthier Living Coalition throughout its lifespan, and has just really been sort of a public champion for the work that we do. And when Blue Shield of California was vetting what organizations they should work with in the state of California, and they did a really robust vetting operations. They talked to Dr. Lorg at Stanford. They talked to Laura Conley. They talked to actually Lisa Ferretti in New York to find out, what kind of an organization would be best at creating this kind of a hub. And I think we were really lucky that Laura, having had us as the technical assistance center for a number of years and being happy with the work that we had done for her, was a very strong advocate on our behalf.
Thank you so much. That was lots of really great information and amazing successes. Jennifer, would you like to answer that question for Massachusetts?
Sure. Thank you, Gina. And I'm just going to very quickly just reiterate something that Diane had mentioned, and that was really the essential nature of developing this kind of single entry network for healthcare providers. And if we were not able to partner with community-based organizations and cover the entire coverage area of a particular payor, like a health plan, I don't think we ever would have, I know we never would have gotten to a place of having contracts that we do have. So the work that you're doing on thinking about developing a network and moving that network forward is something that for us proved absolutely essential. We would not have been able to move forward. With that in mind, the whole idea of developing the network with the purpose of being able to meet the needs of healthcare systems, with that in mind, one of the biggest lessons that we've learned over the last few years, and our network has been in place for about 6 years now, but especially over the last few years, is not all of our attention can and should be focused on meeting the needs of the healthcare system. And we have to do considerable work continuing to maintain that network of community-based organizations. Our community organizations are places like the AAAs and the senior centers, but they also include the YMCA, faith-based organizations, multicultural organizations, anything you can really think of being in the community setting. And that network doesn't stay together just because they want to stay together. There's ongoing work that we have to do in continuing to demonstrate that there is a value to them being part of the network. Sometimes we have contracts, and that allows us to reimburse our community partners for the work that they do, but the value that we have to show as a network to our community partners goes beyond the dollars. It goes beyond the financial piece. So being able to have a statewide license, a multi-site, I should say, a license for programs is key for our community partners. Being able to give them ongoing continuing education with respect to the programs is important. We do bi-monthly webinars and an annual conference in order to keep our community partners and our leaders engaged. Having a website where they can have their sessions posted, their calendars posted, and people can register right online. Those are the kinds of things that it's important to demonstrate value to the community partners. So, one of our lessons was not to lose sight of the maintenance, the work, the value in maintaining the network, as tempting as it might be to focus all of your attention on getting the contract. If you don't have the network to fulfill the contract, you won't have the contract for very long. And then the last thing that I'll mention is while we're maintaining the value of the network, we have also found it to be really beneficial to demonstrate a value to our healthcare partners that goes beyond just offering the evidence-based programs. And what I mean by that is that as a social service or a long-term support provider in the community, you can offer the evidence-based programs, that's great, but in addition to that, remember all of the different resources we connect folks too. So we'll get referrals from providers, and we will have conversations with their members or their patients, and sometimes we're able to get those people nutrition services, or we're able to get them transportation, or we're able to get them other kinds of protective or home and community-based services. So whenever you as a network or individually are thinking about developing your value proposition, what is it that you are demonstrating is valuable to the healthcare systems, don't just stop at talking about the program delivery. Talk about all of those relationships, the network, the connections that you have in the community, and the capacity that you have to touch their members or their patients in a way that the health system isn't currently, specifically when it comes to addressing those social determinants of health. So those are some of the big lessons learned that we've had here over the years in Massachusetts.
That's just tremendous. Thank you for that overview. Some great pearls of wisdom and lessons learned. I'd like to, at this time, allow anyone to ask some questions, some follow-up questions, again, through your chat box, or unmute your phone. This is the time. We have them on the line. And again, if there are questions afterwards that come to mind, please feel free to ask through the systems that we will be sending out with the survey or email, or again, you can put them into your chat box if something comes up for you and you're more comfortable putting those questions there. So thank you both so much for providing that overview. Is there anything else that came to mind while you were sitting and listening to each other that you would want to add to this question?
I think they would, go ahead, Diane, sorry.
No, I wasn't saying anything. I'm thinking about barriers right now, and I have some good ones there.
Yeah, one of the things I was just going to mention was a barrier, a challenge or a barrier as well. And one of the things that we're continuing to focus on and to think about is our data collection systems and the feedback that we're able to give providers. And I think you'll hear from a lot of folks who are doing this contracting with healthcare that the measures of success that we traditionally think of when we do our programs may not be the same measures of success that healthcare needs to see. For example, it's really important to us when people have high satisfaction rates and high completion rates, and we have testimonials and stories about how wonderful the programs have been for them. Those are great things to sort of open the door with healthcare, but many, not all, but many of our healthcare partners want to see real data with respect to any changes they've had, and those changes can, on the very low end, on the minimal end, be self-report kind of changes, but once we get into real contracting, oftentimes, again, not every time, but oftentimes they're looking for information that moves the needle with respect to hospitalization, readmission, and oftentimes that requires a true partnership with the healthcare provider. The plan is going to have access to health utilization data that we as a community-based organization will rarely, if ever, be able to aggregate. So as you move forward, sort of thinking about the importance of reframing what success means, not forgetting what success means, but expanding that definition. It's not just satisfaction, it's satisfaction, activation, health utilization, all of those sorts of things. And I think everyone's still struggling with how to gather that data, how to share that data, and how to increase our value proposition on that data. And I know, Diane, that's also something that you all struggle with and I think have moved the needle further than anyone else. I don't know if there's anything you wanted to add.
Yeah, actually, that IT systems was really what I was thinking about when I think about greatest barriers, and it's kind of interesting because, I think we all think that IT systems really are to take care of barriers or, to move them out of the way. And I think I hope ultimately that is the case. But I know we use a Salesforce database is our, and Salesforce is a contact relationship management system, but it's a very pliable IT system and can be programmed to really do a great, take care of a great number of different data collection issues. And what we have found working with the plan is that they require much more detailed reporting than we have ever had to do. And it's not even the types of outcomes that Jennifer is talking about. And I really hope for the day when we actually get to the point where we're able to really see the return on investment so that we know that we have reduced hospitalizations, or we know that we have changed the number of emergency room visits of folks that have actually gone through our programming. But at this point, what we are working on is we do outreach and engagement of participants through our contact center in what I would say is a true population health type of program where last year we got 75,000 referrals from the plan in data drops. There were probably 6 data drops over the year. And we take that data and create what we call campaigns out of it. So we'll look at where we have a workshop scheduled, and then we'll drop on a geomapping program, we'll drop a population, the plan's population that they've sent to us around that program area and create what we call a campaign. And then we send that campaign to a partner who does mailing to that population of members. And then 3 to 5 days after the mailing, we start doing automated calls out to that population to try to enroll them into the chronic disease self-management programs. And we have 3 different IT packages. So we have what's called IVR, or the robocalling piece. Then we have something that's called a dialer that actually controls how fast those calls come into the contact center to the people that work in the contact center. And then we have Salesforce, which records much of the activity and whether the participant has been enrolled in a program, which of the 3 programs they've been enrolled in. And getting those 3 different IT programs to talk to each other and upload information, referrals in the way that it's supposed to has been a significant challenge and continues to be a challenge. And every time the plan changes some requirement or something that they would like us to do, that will once again affect the programming that happens in Salesforce. And so it's an expense that I don't know that we could have forecasted. And, we are still not with all of the resources that we've thrown at it, we are still not 100% where we would like to be in terms of automation. So, I think IT challenges like this are not, I came from a large health system, and I saw the challenges that those health systems went through putting in electronic medical records and then trying to integrate physician office records with hospital medical record systems. And it's the same type of integration issues that that I saw in those health systems years ago, I am now feeling the pain of here at Partners. So that for us, I think, is been a huge focus. And then I think the other piece is really what Jennifer has already spoken about, which is keeping our network happy. And, I think she speaks eloquently about the importance of keeping that network engaged. And that is, we don't control how many referrals come from the plan in any particular region of the state. And so if we've asked a partner to stand up a workshop, in a somewhat rural area, or let's say the Central Valley of California, and we have no control over how many referrals we're going to get for that area, or how many of, we have a little more control over, once we know how many referrals we get, how good of a job we do of enrolling people in those programs. And there's been some definite disappointments and a lot of hand-holding that we've had to do to sort of reassure our partners that, we are working on getting more contracts, that, in the future we hope to be able to provide them. We may only provide to a particular workshop, there may only be 2 Blue Shield members that are actually enroll in the program in a particular area, and if they've stood up the workshop for us and only get 2 members, they may not be, completely happy with us. So it's over the 2 years that we've been working with our network in this more formalized manner, and where we're actually paying them for the people that come through this Blue Shield contract. We've gone from sort of saying that, we would be able to fill an entire workshop, to saying, no, we're not going to be able to fill an entire workshop. We're going to be able to give you a few people, and the rest of the folks you're going to have to be able to recruit in the way that you're used to doing on a grant basis from your own community.
Again, thank you both for sharing that information. I know it's a lot to absorb and hear if you're hearing this for the first time. I have enjoyed listening to both Jennifer and Diane over the years through webinars, through NCOA, so that resource center link that you keep seeing in the slides. You can get access to a lot of this information if you need to hear it again. We are recording this, so again, you'll have some time to hear it again and digest the information. And so if there are any questions that anyone has in response to Jennifer and Diane's comments on question number 2, or any other questions? Okay. So I do have a question, Diane. So what I heard you saying, and correct me if I'm wrong, that it sounds like if you had more contracts with multiple payers for utilizing the contact center, then you may have more success in filling workshops in especially hard-to-reach areas that may have multiple plan membership in those areas. Is that correct?
Well, yeah, I think, the bottom line is that when you're doing this kind of, and I don't know, Jennifer, if it's the same for you, but where we're doing this sort of real population health outreach initiative, and we don't have a physician referring the patient into the program, and the patient hasn't said, I want to go to the program on their own. So we are outreaching to them, in this telephonic way, and they have shown some interest because they've decided to press 1 because they have some interest in the program. And then we take them through a motivational interviewing script and try to find their own intrinsic reasons for wanting to participate in the programming. But still, we're only getting penetration of 2 to 3% of the population that we get, right? And that's considered good. Like if you look at national statistics on this type of an outreach program, that you know, the goal was between 1 and 2% initially, and we're between, you know, 2.5 to 3.5% is what we're getting. And so we just can't say that we can fill up an entire workshop with people out of this type of approach in an area that's not densely populated. You know, in Los Angeles, we still don't always fill an entire workshop. We may send 8 members so that, you know, they need to get 2 to 4 more people to complete the workshop. And that's often because of limitations on where people are willing to travel to. You know, they may not go past a certain freeway on a regular basis. So, you know, there's a lot to learn. But our hope is that if we have more than one contract, so we have multiple plans that we're contracted with, then even in those more sparsely populated areas, we'll be able to provide more participants for a particular workshop. Jennifer, do you have experience with that type of an issue?
Yeah, thanks, Diane. I think our experience is very similar, if not identical to yours. I think one of the things that has helped in Massachusetts is that for some of the contracts, we do have the capacity for folks to self-refer, self-identify. So if we have a contract with a managed care organization and their member just walks in off the street, that is somebody that is covered under the contract. So a community-based organization will oftentimes do a lot more marketing and outreach in their communities, particularly if their community naturally has a large penetration of one of the health plans. And so that does help fill seats in that way. We do a very similar process, as Diane mentioned, with respect to the motivational interviewing conversation. We are fortunate in Massachusetts in that because we are so much smaller than California and have, as a result, smaller populations, smaller contracts, we don't use a robocall system, but instead there are live people who are making the calls. We would not be able to do that if we were in a system like California and getting those numbers. And I think those live calls from the beginning have helped us with increasing our enrollment rates. But again, it's sort of a chicken and the egg. We can do it because we don't have a ton of contracts. We want a ton of contracts. When we get a ton of contracts, we might not be able to do that personal touch as much. So it is a challenge all the way around, but one that I think everyone is working towards improving, and a challenge that I will accept as opposed to the alternative, which is, you know, no capacity to contract with healthcare.
I guess, and I do want to say one other thing. We have seen in the contact center, we are using a different kind of dialer now. On the first pass, it's a regular old-fashioned IVR, so robocall, where you'll hear what's called a pregnant pause on the line before there's a transfer over to someone in the contact center. We now have so we do 3 passes of calls. The first pass we continue to do is a traditional robocall, but then on the second pass, we use another method that our new dialer is capable of doing, where you no longer hear that pregnant pause, and if a live person or an answering machine picks up, it immediately transfers to someone in the contact center without any wait whatsoever, and that has increased the enrollment time, or the enrollment, percentage. So, I guess what this really says is there's just lots to learn in this type of approach, which is really new to community-based organizations, right?
Yes.
Absolutely.
And I have to say, as being fairly new to this area of evidence-based program delivery in the NCOA world, it's somewhat comforting to know that you still have barriers and challenges, because as you can probably think back to the earlier days of implementing this, when you didn't have all this information to start with, it's even with all this information, it's still a great challenge to get everything operating and running, and like Jennifer said, making sure that network is developed and sustained and maintained and supported, and then adding in the elements of trying to fiscally sustain the network and the work that we're doing. There are so many elements that I think everybody is seeing through these presentations that are required for sustainability and success. So, Kim, did you have a question?
Yeah, my question, and this is maybe also in part because I have looked at your online website, and they're very nicely put together. But maybe for the benefit of the group who may not be familiar with online prevention and management education, can you talk a little bit about your experience with referrals to online programming, if any, and maybe any tips or tricks that you found work?
So I think I'll take that, Jennifer. Does that make sense?
Yes, please.
Yeah. So this is Diane, and we do in our program with Blue Shield, we offer 3 modalities of the chronic disease self-management program. We offer in-person and local in community-based organizations throughout California, and then we also offer the online program, Healthier Living Online. And then if both of those are refused by the member, then we offer them a toolkit that's also been created by Kate Lord and at Stanford. So the online program, honestly, for certain people, we present them as absolutely equal options. And what we find is that almost an equal number of people take the online program as take the in-person program. And, unfortunately, I don't have data that tells me, that helps me to really understand or drill down into why, a person decides to do one versus the other. But what we do know is that about half of the folks take the toolkit, and a quarter of them take the online program, and a quarter of them take the in-person program. And really, I think, I can surmise the reason that people go online, but it's really not scientifically derived.
Thank you, Diane.
Yeah.
Okay, so are we ready to move on to question number 3? Are there any questions from the audience? Okay, so question number 3 is pertaining to your champions and some of what you alluded to, Jennifer and Diane, about maintaining the network. Who have been your greatest champions in establishing and maintaining a program delivery network? I didn't delete the details from our email, so who are your champions when we think of state and local leaders, and even those who are, who assist in developing and maintaining master trainers and lay leaders. So Diane, do you want to go first, or do you want to break and let Jennifer speak first?
Jennifer can go first if she wants. Would you like to, Jen?
I have no preference.
I don't either. So you go ahead.
Seeing silence, I'll go ahead. So yeah, with respect to maintaining the community-based network for the delivery of programs, the strongest partners and advocates and champions that we have with that network are by far the AAAs, the Area Agencies on Aging. They have worked with us so that there's a shared understanding that the value of these evidence-based programs fits in perfectly with their individual missions in order to reach aging adults in the community. And because they have integrated as part of their strategy in achieving that mission, it means that they are committed in good times and in bad times. So in times where there are lots of grants and contracts and they have resources coming in from the Healthy Living Center, they're there. And times where we have a little bit of a dry spell with respect to sustainability, they continue to be there because they have integrated it as part of their mission. And I think the best sort of illustration I can give of that is, in 2014, 2014 to 2015 was the last year that we had grant funding for our chronic disease programs. And in that year, we reached only about 200 more people than we did the following year when we didn't have grant funding. And a part of that is because of contracts, but a big piece of that is because it's been embedded primarily in the AAA network. A collateral champion, a champion that sort of helps support the AAA networks in making that part of their mission, has been our State Unit on Aging, the Executive Office of Elder Affairs, who have not only, sort of eased the path for data collection and for reporting for Title IIIB purposes for the programs, but have very proactively gone after additional federal and state funding to support the Healthy Living Center and have advocated for the work to the degree that they can. So our State Unit on Aging is a large champion for us. Our Department of Public Health as well, they advocated for and helped advance a Prevention and Wellness Trust Fund here in Massachusetts, which designated meaningful dollars towards these evidence-based programs and the Healthy Living Center as the centralized structure for those programs. And I think, one of the probably not so surprising but oftentimes forgotten high-level champions that we have for the programs and for maintaining the network have been our participant champions. And as we've grown, we have more and more folks who are completing the workshops. Now they're activated. That activation doesn't end with their healthcare activation, but it includes additional social and community activation. And so they are not only running sessions, but they are part of the recruitment and marketing team. They are some of the folks who answer the phone when we have participants call in and want to know about the program. And an important piece of maintaining the network is getting those folks to who call in to actually sign up and register for a program, and our participant champions are able to say, yeah, me too. I was nervous about attending the program. I didn't want to sit in, but here's why I did it, and here's why I'm glad I did it. So those participant champions are really important to maintaining our network as well. So, Diane?
Hi. So I think here in California, really the Los Angeles City. So we had kind of unusual because of our size. I think we have both a city and a county Department of Aging, and the Los Angeles City Department of Aging, led by Laura Trejo, has been really a leader nationally in evidence-based programs and the promotion of evidence-based programs. And, that's where we've been the technical assistance center for the city for 13 years. And with Laura's leadership, she's just been an amazing champion on our part. And then, as I already said, the California Department of Aging, with Laura Connolly, has also been a huge champion of the work that we're doing and of the chronic disease self-management education across the state, and promoting that as in a kind of way that it's really a passion I think, for her. We've also worked very closely and gotten some additional financial support from the California Department of Public Health, from the arthritis section of the Department of Public Health. And they have been involved in the Healthier Living Coalition for probably 7 or 8 years. Recently, the County of Los Angeles has sort of joined with the city AAA, and they are working on what's called purposeful aging across the County of Los Angeles, and has taken on this evidence-based work as a integral piece of that purposeful aging initiative. And then we also have a very large health system, Dignity Health, which is one of the largest health systems in the country. And Dignity, right from the start, was a real champion and extremely supportive of this work, has always worked with us as a partner on any of the Administration for Community Living grants that we've had. They have a broad network because they have hospitals all over the state of California, so have been very helpful as partners in our formalized network hub contracts that we do for Blue Shield, and have just really been great champions. But I think there's something that I want to say about, how important individuals are who are in leadership positions, because we've had in the last couple of years, and are going to be having more, turnover with people retiring. And as people retire out of these leadership roles and new people come in, there's a tremendous amount of rebuilding of relationships that has to happen, and a great deal of history that is unfortunately lost. I guess a learning from that is to try to build as broad of a relationship as possible within some of these organizations, so that when people do leave, either for retirement or get in some kind of a new position, the entire relationship doesn't have to be sort of brought back from the beginning. I mean, we've had turnover in Dignity Health, in Kaiser, and soon to be in some of the other major positions. So that, for us, has been, a big learning. And then I really like what Jen said about the participants themselves being key champions, because I very strongly agree with her. And I think I would even add to that is some of the volunteer leaders that we have really put an amazing amount of energy into this work and speak of it within their communities very broadly, and have been also huge champions for the work.
Again, thank you both. Again, lots of lessons to digest and learn and determine. We know we can't do everything. We have to start somewhere. So hearing your first, second, and third wins early on, I think were really helpful. As you know, each state is unique. So, we're hoping that the partnership that we have on the call can has been listening and has some ideas about, some thoughts about how we might want to move forward in Pennsylvania. And that's the purpose of creating at least some baseline of a sustainability plan. We realize it's not going to be comprehensive, it will be a living document, but at least it's a starting point. Did both of your states create sustainability plans as a part of your earlier ACL grant funding?
Yes. So
Yes.
California has a sustainability plan, and Jennifer has the most beautiful business plan that you've ever seen. I wish my plan was as robust as hers.
I do believe there's, again, I think I mentioned early on that the NCOA CDSME Resource Center is just chock full of great information and resources, and you know, we don't want to reinvent the wheel if there are models out there that are exceptional, and we hope to get buy-in from the Leadership Sustainability Group about what types of models we want to use. We're just focusing right now on sustainability and not necessarily the business plan, but we realize that that's a really important element to it. And, you know, hopefully that will be incorporated into the sustainability plan as maybe an action item that we need to look at, you know, at some point in the future. Okay, go ahead. Okay, so everyone on the call, this is your opportunity to ask any questions of Diane and Jennifer. We have a couple of polling questions that we would like to close out the call with that we were not able to show earlier. So we will transfer the screen back to our colleague here in the room, and I just want to thank Diane and Jennifer so much for your time. We know you're very busy and dedicated to your work, and you know, we really appreciate you taking the time and your thoughtfulness in answering and responding to the questions. This is being recorded, so we can share the recording with you if you'd like to have that, as well as we'll be sharing it with our leadership network and conducting a survey post-meeting. We have 3 more meetings scheduled, and we will be speaking next week about best practices around marketing, promotion, and referral strategies. So this was a nice jumping point for that conversation next week. So thank you both for your time. If you'd like to stay on and see how people respond to our polling questions, you're welcome to do that, or you're welcome to sign off.
Thank you, Gina. It was a pleasure, and please do reach out if you can help in any way. Good luck to you all.
Yep. Thank you. I second exactly what you said. Thank you, and really good luck to all of you.
Thank you, Diane. Are we going to do this with staff? Okay, so if you have text messaging, you can text to HPCPA to 22333, and you can answer the questions. So our first question is, should the state consider establishing a designated steering committee or advisory group that guides and provides input to the delivery network and the delivery of evidence-based self-management programs in Pennsylvania? And of course, these are anonymous, so it's just a nice little way to see, engage how the group is thinking at this point. So your first option is yes, create a new one. No, there are too many groups as it stands now. And no, consider exploring an existing group for feedback and input rather than creating a new and separate advisory group. I apologize that we weren't able to give these instructions earlier on. Okay, so it looks like we're having some technical difficulties. I'm getting a response that the program has ended, the texting. Oh, there we go.
Yeah, good.
Okay. We'll also be asking this in our post-survey to see what people think about how we might want to gather input into the future on this work across the state. Okay, next question. So, in your thoughts and listening to Diane and Jennifer and hearing the best practices, if you have any ideas on what type of organization would be the best option to serve as an effective network hub to reach the largest numbers of vulnerable populations. I think one thing that didn't necessarily come up with Jennifer and Diane's report was that their work also expands beyond the aging and disabilities population with diabetes prevention and so on. Okay. And again, we'll ask some of these questions in the post-survey. I don't want to take any more of your time. Okay, so in closing out our call today, just want to talk about the next steps. We will be distributing the meeting recording and notes. I apologize for those of you who are not able to access this information via Google Drive or Dropbox. We will be asking you if you are interested in us exploring an FTP site where there's more secure exchange of information, and maybe you'll have access to that. I did try to send out information by zipping the files as well as sending individually. The recordings are very large, so unfortunately it's difficult to send the recording, but we can at least send out the slides and the notes and other information. If there are any new partners that we should invite to this group, please let us know. We will, between now and next call, begin drafting a skeleton of the sustainability plan. And our next meeting is not Thursday, but it's actually Wednesday, July 19th, from 12 to 2 p.m. And the topic is, as I mentioned before, best practices in marketing, promotion, and referral systems. So thank you for your time and your attention and your commitment to these calls. We know it's a very tight timeline and a commitment to several meetings. That's why we're making them available in other formats and trying to gather input from you directly. If you would like to speak directly to us in more of an interview format to try and gather your thoughts and feedback, we would be happy to schedule a call with you. Just let us know. You can send an email to myself or anyone on the team, HPC. So thank you for your time. Enjoy the rest of your week, and wish you all the best. Thank you.